Hello, my name is Dinesh Baborji. I'm a PGY2 with Family Medicine. This is the video for the impact of best practice advisories on hypoglycemic event rates, a comparative analysis before and after. So the background of this is a leading cause of mortality and morbidity in the hospitalized patient is hypoglycemia, which can be very dangerous. So has many different etiologies, and we felt that many of which were avoidable if we could kind of come up with a system to have a check when changing certain things with patient orders, including eating status and insulin regimens. So the aim statement was we aim to reduce the events of severe hypoglycemia in the hospital by evaluating the most common causes and implementing measures to reduce these events. Severe hypoglycemia is defined as a glucose level of less than 54 with altered mental status or needing outside assistance to administer medications to bring your glucose levels up. The methods was we looked at through EMR data pulling any patient or events that had serum blood glucose of less than 54 with the need of assistance. And then the patients were identified by their MRNs and episodes of hypoglycemia. We sorted them in categories of patients that were NPO or non-eating, drug-induced hypoglycemia, poor oral intake, and multifactorial reasons. They were reviewed 3 months before and 3 months after the BPA was implemented, which was in November of 2023. The BPA itself is a best practice advisory. So when a provider, such as a resident or attending, places an order, specifically insulin orders or a change of diet, the BPA would trigger and alert the provider to double check the existing insulin regimen with the corresponding new order placed and to reassess those and to double check if that is the appropriate insulin regimen or if the diet order is appropriate as well. August 2023 through February 2024 was reviewed, and we excluded November of 2023 as the BPA was implemented then with the kinks getting worked out. So as you can see with the data there in the middle, the multifactorial had 49 events prior to the BPA, and then it significantly reduced to 21. Medication adverse effects roughly stayed the same, going from 11 to 12. NPO slightly improved from 5 to 3 events, and then poor PO intake or by mouth was increased actually 2 to 11 based on the random sampling of the data that we took. So basically the variables are total incidence of severe hypoglycemia before the BPA was 67 and after was 47. The absolute risk reduction of the hypoglycemia is 12.36 before and 10.67 after. And then absolute risk of severe hypoglycemia is 6.27 prior and 5.17% after. And putting them into biostats. So absolute risk reduction was 1.09% of hypoglycemic. Absolute risk reduction of severe hypoglycemic events was 1.10%. And most interestingly, the biggest changes was the relative risk reduction of hypoglycemic events was 13.67. And then if we check the severe hypoglycemic events, the relative risk reduction was a good 17.57%. So what does this mean? With the implementation of the new BPA, there has been a total decrease in the rates of hypoglycemia and severe hypoglycemia events at OSUMC, evidenced by the absolute and relative risk reduction values. So that's great news. The BPA really just gives the provider a moment to double check insulin regimens. Insulin can be, very dangerous. It can kill someone. It can cause severe adverse side effects, increase hospitalizations. So sometimes we get used to these medications, but they're very serious medications. So it's good to have a double check with that BPA. The discussion leads to basically the rates of multifactorial causes of severe hypoglycemia may be better evaluated in future studies by indicating if the multifactorial cause is avoidable or unavoidable. The poor PO intake was a little difficult and makes sense because that is more something that happens inpatient if the patient is not feeling well. It's an event that the patient kind of triggers that it's hard to get ahead of. So future considerations for that is more interventions may be done in the future research, including resident nursing education, updating insulin flow records in the flow sheet portion of the EPIC EMR with the patient's diet. And more clearly, this is done now a little bit, but it's not very consistent, how much of the patient's meal that they've consumed. So very often you'll go to the flow sheet in EPIC and see that they've consumed 25, 33, 50, 75, 100% of their meal. And we can get an idea of their poor PO intake or just overall intake there. So that would be the next step we would take. And acknowledgements, we fully acknowledge the contributions of the residents of Family Med, IM, and Emergency Medicine under the guidance of Dr. Tiller, and OSUMC for providing the resources and framework to make this initiative possible. Thank you.